Let's now start a very interesting module and something which I love to teach, that is regarding drains, knotting techniques and suturing techniques. Now, this is something which makes up practical surgery and we do it in our daily routine. And I want you to know these details because not only are they important from the practical point of view when you start working as interns, but also lots of MCQs are asked. And unfortunately, these are things which are usually not taught in colleges. So I want you to pay attention to this module because it is very important in the overall scheme of things. First, let's talk about surgical drains. I'm sure if you've gone to the surgical ward, you must have seen that after surgery, there is a drain bag hanging, right? So there are various types of surgical drains which we insert, and I want you to know some of these drains. Now, these drains can be open drains or they can be closed drains, right? Usually open drains we are not using now. We usually use closed drains which drain into a container. The open drain which was used earlier was a corrugated rubber drain. And I remember when we were interns or we were doing our post-graduation early on in Safdarjung, at that time if we used to drain an abscess or drain a collection, we used to put this corrugated rubber drain and pus or fluid just used to trickle out. This was put through the cavity. This was the cavity and it used to come out from the skin and it used to just trickle out. The contents used to trickle out and every time the dressing used to be soaked. So it was a very messy affair and sometimes it used to get pulled out as well. So this was an open drain known as a corrugated rubber drain. Now, something which I use most commonly is the Romovac suction drain. This is the Romovac suction drain and I use it after mastectomy. I use it after lymph node clearance. This is also used after neck dissection. This is used after oral cancer surgery if you've raised a flap. So those are the places where this Romovac suction drain is used. And this sharp end is put in and this sharp end is put in and this is connected to this drain. Now this Romovac suction drain is a closed drain. It is a closed drain and it is a negative pressure drain. You can create a vacuum, right? And you can create negative pressure. So you would have seen in the ward the resident cleaning this drain and then one person presses it and the other person closes it. So you can create pressure and it creates negative pressure, so it brings out all the fluid which is accumulated in the cavity. Another question which has been asked, after breast surgery we remove this drain when the output is less than 40 cc per day for 2 consecutive days. For 2 consecutive days, that is when I pull out this drain from the patient, right? This question has also been asked, and if you pull out this drain early, then a seroma or fluid accumulation can occur. Now, a miniature version of this drain is called the mini-vac drain, right? It's a miniature version of this drain, and I use it when I'm doing a sentinel lymph node biopsy, where I haven't cleared the entire axilla. I've just sampled the lymph nodes. There I just keep the sentinel. There I just keep a mini-vac for 2 or 3 days and then I remove it. So it's just a smaller version of the Romovac drain. This is also an example of a closed drain where you can create negative pressure or negative suction. Another one which is used is Jackson Pratt, and I saw this being used a lot in America. And this Jackson Pratt is used after abdominal surgeries. This is also a closed system where negative pressure can be created. Now, the main difference between Jackson Pratt and Romovac and Minivac is that in Romovac and Minivac, you can see that it was a circular tubing. This tubing was circular. Whereas in a Jackson Pratt drain, the end of the drain is flat. The end of the drain is flat and you can see these multiple openings which are there which help in draining out the collection. So this is flat, unlike Romovac or Minivac where it has circular tubing. This Jackson Pratt is a flat tubing. I've already shown you a corrugated rubber drain. Abdominal drains, what we commonly use in India, once you open up the abdomen, you will see this in the ward that on the side of the bed this abdominal drain bag is hanging and this is the abdominal drain which is put in. Now usually these drains, when we put them inside the cavity and we have to fix them with the skin. So how do we fix them with the skin? We will either use silk or nylon. Silk or nylon is used on a cutting needle to fix these drains. I will tell you about these various suture materials and what are cutting and round body needles in this module as well. This is an underwater seal bag. This has also been asked in various exams, and I've covered this in great detail in the thoracic trauma module, where I've shown you about chest tubes. So underwater seal bag is connected with chest tubes, right? And the main difference between an abdominal drain bag and an underwater seal bag is that you have a pipe running right down till the bottom here, and this lower half is filled with water. So the lower end of the tube is submerged underwater. That is why it is called an underwater seal bag. And the reason why it is submerged underwater is so that if we are draining a pneumothorax, then air can come out and air will not get sucked inside again, right? Again, air will not get sucked inside and go into the thoracic cavity. For more details, please refer to the thoracic trauma module, where I've spoken about chest tubes, and you'll be able to understand this thing better. So that was regarding surgical drains. Now let's start talking about knotting and suturing techniques. The first thing which I want you to know are the basic knots, because whenever we use a suture, we ultimately have to tie knots. So the simplest knotting technique is known as a square knot, and I'll use the simple iPhone charger to demonstrate to you what a square knot looks like and how do we actually take it. Now, just for the sake of understanding, I want you to know that this is the broad end and this is the narrow end. In a thread or in a suture, you don't have a broad or a narrow end. This is just for your understanding, okay? Now, if I cross this, right? So the broad end is here, narrow end is here. If I cross this and cross it once like this is known as a square throw, right? This is known as a square throw. And if I cross it once more, if I tie it once more and cross it again, then it becomes a square knot or a reef knot, right? So if we look here, we've crossed it once. This is known as a square throw. And if you cross it once more, then you get a square knot or a reef knot. So two square throws make a square knot or a reef knot, and this is a secure knot. This does not open up. This is a secure knot. It does not open up. Okay. You can see here sometimes nature can also entangle itself in knots, and this is a tree where this knot is made. So this is a square knot made from a tree, and I've just explained to you what square knots are. Now, another type of a knot is a granny's knot. So I want you to understand the difference between a square knot and a granny's knot. So the difference between a square and a granny's knot is that in a square knot, I was crossing, right? Whereas in a granny's knot, this broad end is on this side, the narrow end is on this side. I don't cross, right? The narrow end remains on this side. Again, I don't cross. The narrow end remains on this side. So if I don't cross, that gives rise to a granny's knot. And the difference between a square knot and a granny's knot is that a granny's knot is an insecure knot, also known as a slip knot. It slides easily, it opens up easily, okay? So I'm sure all of you can associate with this. My grandmother used to make a lot of sweaters for me, and I was very close to her. Unfortunately, we lost her last year. So, she has made a lot of sweaters for me, and those would be my prized possessions or my memories of her. But, I remember when she used to make me stand and she used to measure the length of the sweater. And what she used to do was she used to take 19 or 20 granny's knots, and the last one she used to cross and secure. I'm sure your grandmothers would have also done the same for you. Now what happens is that if the last thread of your sweater opens up, you would have seen that you can pull out the entire line. Why can you pull out the entire line? Because your grannies use granny's knots, which can open up easily. They are insecure. So as opposed to square knots, these granny's knots will open up easily. Now, another question which was asked in the NEET exam was, how do you differentiate them on such an image? If you're shown an image like this, how do you differentiate whether it's a granny's knot or a square knot? So look carefully. If we look at it here, you can see that this white thread is going above the loop here, and it is going above the loop here as well. Okay, going above the loop, and on this side it is going below the loop, and it is going below the loop. So if it is both above and both below, then it is a reef or a square knot. But if you look here, in a granny's knot, one thread is going below, right? I'll use the same color so that you can understand. So one thread is going below, the other thread is going above. Similarly, on the other side, one thread is going above and the other thread is going below. So if you have alternate, one above, one below, then it is a granny's knot. If it is same on both the sides, then it is a reef or a square knot. So this is how you can differentiate it on such an image. Now, this is basic understanding, and whenever a first year postgraduate joins or an intern joins, we keep on telling them to cross the knots. Otherwise the knot can open up. And sometimes if you're not careful, you can make a blunder in the theater while tying your pajama, and your pajama can drop like this and it can be an embarrassment for you. So no granny's knot when you're tying your pajama. Alright, always use a square or a reef knot while tying the pajama. Another type of knot is a surgeon's knot, right? Now, surgeon's knot, how is it different from a square or a granny's knot? So in a surgeon's knot, what we do, we cross 2 times, right? We cross 2 times instead of a single time. So in a surgeon's knot, we cross 2 times instead of a single time. So you can see here, I've crossed once, I've crossed once more, so 2 times I've crossed, and then I cross a single time. So 2 throws followed by 1 throw is a surgeon's knot, right? So you can see here, this is 2 throws followed by 1 throw is a surgeon's knot. Okay, so this is also a secure knot, like reef or grannies. This is also a secure knot. Now, interns who are watching this video, have you done suturing? If yes, have you taken a surgeon's knot? All of you have taken a surgeon's knot. Now, if you remember, you tie the thread 2 times around the needle holder first time around, right? You rotate it 2 times around the needle holder and then a single time. So what you're actually doing, knowingly or unknowingly, is that you're taking a surgeon's knot. So these are the 3 basic knotting techniques which you should know about. Now let me demonstrate a video where I tell you how a square and how a surgeon's knot is taken. So in this edition of Marrow, it's our endeavor to take you right down to the clinics and to teach you some practical skills as well, which will be important for your exams and also when you work as interns. Now I want to demonstrate suturing techniques and knotting techniques to you. Before I do that, I just want to cover up some basic things. So whenever we have to do suturing or knotting, we require 3 main instruments, and these have been asked in the exam. What all do I need? I need a needle holder, which I've demonstrated in the instrument module as well, which has crisscross serrations and a groove in the center. When I'm doing skin suturing, I need a tooth forceps with which I can hold the skin, and I need straight scissors to cut the suture material, right? This was asked in the All India exam 4 years back. So these are the 3 instruments which we require for skin suturing. Now the first thing which we need to talk about are the knots. And remember, I told you about a square knot and a granny's knot. So that's what I'm going to demonstrate to you now. So I'm going to take my suture material, and here I'm taking Vicryl. Vicryl, you know, is violet in color, and it's a braided suture. It's a braided suture which I'm taking, okay? So first I'm going to demonstrate to you about a square knot, okay? And like I told you, we've covered this in the module and you will listen to this later on. We hold the needle at the 1/3, 2/3 junction. This is the swaged end. The swaged end is the one where the thread is attached, and this is the pointed end of the needle. So the needle is always held at the 1/3, 2/3 junction, 1/3 from the swaged end and 2/3 from the pointed end. Okay. Now, whenever I take any bite, the needle is always going to enter at right angles with the skin. This was another question asked in the INI-CET exam. So the needle is entering at right angles with the skin. So now we are going to talk about a square knot and a granny's knot. So you can see here, this is my needle which is entering, and this needle has come out on the other side. It has come out on the other side, and you can see here that this is the V which is formed. Okay, I want you to notice here, this is the V which has been formed. Now a square knot, okay, square knot was when we were crossing. So square knot is when I wrap the thread once around the needle holder, and I wrap the thread once around the needle holder, I'm going to hold the suture and I'm going to cross, right? I'm going to cross. So I've crossed here, okay, I've crossed here. This is how I've crossed. Now I'm going to take the next bite and I'm going to cross again. I'm going to cross again. Again I'm going to take a bite, and again I'm going to cross. Again take a bite, again cross. So every time I'm crossing. Now when I'm crossing, you can see that I cannot open this suture. This is a secure knot. I cannot open this up, right? So this was the example of a square knot. So now I'll demonstrate to you what a granny's knot is and how does it open up easily, okay? So I've again taken the bite which I've taken at right angles. This is my needle which has come out on the other side, and this is the V which is formed now, okay? Now we normally stay inside the V, but now if I don't cross, okay, if I don't cross, that means the short thread is here only. I haven't crossed. So you can see when I'm not crossing, the knot itself is not forming properly. Okay, but I'm not crossing. And I again take a throw, again I don't cross. Again I take a throw, again I don't cross. Now this is a granny's knot. And why is it called a granny's knot? You can see that if I just pull on this thread, can you see how this knot is opening up? If I just pull on this thread, you can see that this knot has completely opened up. And that is why this is known as a granny's knot or a slip knot, and it opens up easily, which is why you should not do that. You should always cross your knots. Now the final one was a surgeon's knot. So in surgeon's knot, what are we doing? This is the V which we have, and we are going to stay inside the V, okay? So in square knot, I was only crossing once. I was wrapping the thread once around the needle holder, but here I am wrapping the thread 2 times around the needle holder. So you can see here that I have wrapped the thread 2 times around the needle holder, and then I am going to cross, right? I am going to cross, okay? Then I am going to take another bite and I am going to cross again. I take another single bite, I cross again. I take another single bite, I cross again. So this one is also a secure knot, and you can see I cannot open it up. So I have demonstrated to you square knot, granny's knot and surgeon's knot. When you are working as interns, always take surgeon's knot. So 2 wraps and then a single wrap, and don't forget to cross. So with this information of knotting in mind, let's move on to the suturing techniques, right? So first we'll talk about skin suturing, and whenever we have to do skin suturing, please remember we always want everted edges. We don't want inverted edges. If the skin edges are inverted, they will never heal. So in skin suturing, we want everted edges. In bowel anastomosis, we want inverted, but in skin suturing, we want everted edges. So I want you to remember this. Now, skin suturing, one more principle which I want you to remember before I tell you the suturing techniques is that if we are doing skin suturing and if X is the depth of the wound, then while taking bites, the distance between 2 sutures should be 2x. Distance between 2 sutures should be 2x, 2 times the depth of the wound. Whereas the bite on each side should be x, right? Bite on each side is the depth of the wound, but the distance between 2 sutures is 2x. So you should know this. This is from the latest Bailey, and this has been asked in the exam as well. Now the simplest suturing technique is a simple suture. Now what exactly do we do in a simple suture? I'm sure all of you would have seen this, or you would have done it on your own as well. Now, this is a skin laceration. Okay, this is the laceration which is there. And a simple suture is when I take the needle, I pass it from this side, I come out on the other side, and then I tie it. Right? That's a simple suture. Of course, I'll be showing you, I'll be giving you a demo of all these suturing techniques, but this is the simplest way to understand it, that you go from one edge, come out on the other side, and you tie it, and you get a simple suture. So now you can see a video of how a simple suture is taken. So now I'll demonstrate a simple suture. When I was demonstrating the knots to you, I'd shown you simple sutures. So simple sutures, you enter at right angles. That's what I told you. That was asked in the INI-CET exam. We enter at right angles. We come out on the other side. We come out on the other side. Again, I told you a V is going to form. This is our V which is formed. And we are just going to take two wraps, cross, then go on the other, again take a single throw, cross, again take a single throw, cross. So this is our simple suture which we take, and we want eversion of the skin edge when we are doing skin suturing. Now, just in case a simple suture is unable to cause eversion, right? If a simple suture cannot cause eversion, then we are going to use mattress sutures. So when are mattress sutures used? When simple sutures fail to cause eversion. When simple sutures fail to cause eversion, that is when mattress sutures are used. And there are two types of mattress sutures. You have horizontal mattress and you have a vertical mattress. Right, so this one is a horizontal mattress where you can see that we've gone from one side, we come out on the other side, and on the other side we go adjacent to the previous bite, we come back. This one is a horizontal mattress. It would be better understandable to you when I show you the demo. When I show you horizontal and vertical mattress videos, you will understand them. So this is horizontal mattress. Okay. Now, if I have to just demonstrate it on this paper, you can see here, this was my laceration. This was the laceration. In a horizontal mattress, I go to the other side. Now, at the same depth but adjacent, I'm going to come back. Right? So same depth but adjacent, I come back. This is a horizontal mattress where both the sutures both the threads are on the same side, and then you tie it. Vertical mattress on the other hand is when we go deep, right? Vertical mattress is when we go deep to the other side and then we come back superficially. So we go deep and we come back superficially. That one is a vertical mattress suture. Okay. So vertical mattress, you can see here, if this was my laceration, I am going to go deep. I'm going to go deep here, and then I'm going to come back superficially, right? So I'm going to go deep here and I'm going to come back superficially in the same line. Right, so now they're in the same line, one on top of other. That is vertical mattress suture. Okay, that is vertical mattress suture. And both horizontal and vertical mattress, they help in eversion. And they both are hemostatic in nature. Now let me just show you the video of how these sutures are taken. Now, if a simple suture does not cause skin eversion, then we need to take mattress sutures. And I told you there are two mattress sutures. We can take horizontal mattress and vertical mattress. So first, let me demonstrate to you what a horizontal mattress is. So in a horizontal mattress, I am again going to enter at right angles and I come out on the other side. I'm going to come out on the other side. So this I've come out on the other side, right? And horizontal mattress is when I'm going to take a bite now adjacent to this. So I've come out on this side. Now I'm going to take a bite adjacent to this and I'm going to return back. At the same depth, I'm returning back. Okay. So at the same depth, I've returned back. And now you can see that both the threads are on the same side. Okay. And they are adjacent to each other. I will again cross, and when I cross, you can see the two edges have come together and there is eversion of the edges, right? And I cross again and I cross again. This is a horizontal mattress suture. So you can see the two bites are adjacent to each other. Now, how is vertical mattress different from horizontal mattress? So in vertical mattress, I again enter at right angles and I go deep to the other side. So I've gone deep to the other side, right? So I've come out on the other side. This is a V which is there, and now I am going to come back, but in the same line I come back superficially. Okay, so same line I come back superficially now. So instead of a horizontal mattress where it was on the side to side, this is just one in front of the other, and the first bite was deep, the second bite was superficial, both the threads are on the same side, and now we suture it. Now we are going to suture it. This is a vertical mattress. So you can see here that here the bites were one in front of the other, whereas in horizontal they were on the side. And both these suturing techniques cause eversion of the skin. Now another question which has been asked in the exam, that out of these three techniques, simple suturing, vertical mattress and horizontal mattress, which one has the least cut through rate? By cut through rate, what do we mean? That sometimes these sutures can cut through the skin, right? They can tear through the skin. That is known as the cut through rate. So horizontal mattress sutures have the least cut through rate amongst these three techniques. This question has been asked in the JIPMER exam, can be asked in the INI-CET exam, so you should know the least cut through rate is with horizontal mattress sutures. Now, another suturing technique which is done quite frequently these days is subcuticular suturing, and lots of questions have been asked in the exam as well. Now, subcuticular suturing is cosmetically better. Because in subcuticular suturing what is done is that all the bites are taken from inside. And there is no mark. Right? There is no mark on the surface of the skin. So this is cosmetically better, and this is used wherever we want a good scar, right? Or we don't want the scar to be visible. And usually 3-0 monocryl on a cutting needle is used for subcuticular suturing. At some places we also use 4-0 or 5-0, but most commonly it is 3-0 monocryl on a cutting needle. I will explain each of these terms to you in this module itself. For the time being, you can just note this down, that for subcuticular suturing it is 3-0 monocryl on a cutting needle, and then I'll explain you the details. This question has been asked many times in the exam. Let's see a video of how subcuticular suturing is done now. So you've seen in the interrupted sutures, in the simple and the mattress sutures, that the bites were being taken from outside. So this leaves a mark on the skin. But subcuticular suturing, we will take all the bites from inside, and it is cosmetically better. So you can see here, this is my suture material which is with me, and I am going to take bites all from the inside. So these bites will not be visible on the surface of the skin, right? So this is the bite which I have taken. And you can see here that there is no mark which is coming on the surface of the skin. There's no mark which is coming on the surface of the skin. Again, I take a bite from this side, and you can see here that all the bites are from inside. So there is no mark on the skin, and this is cosmetically better. And the suture material which we commonly use for this is monocryl. The reason why I am not using monocryl is because it is literally transparent and you will not be able to make out what I am doing. But I am taking bites from inside, and you can see that there is no mark on the skin. Now there are other suturing techniques also which are there. And some of the suturing techniques are continuous sutures, where we take continuous bites, and I will demonstrate a video of interrupted sutures I've already told you, which can be simple or mattress. You can have buried suturing techniques where the suture is buried inside, right? Where the suture is buried inside. This also I will demonstrate. You can have a running locked suture. This is a running locked suture. And the advantage of a running locked suture is that it helps in distribution of tension. Right? Helps in distribution of tension. That is a running locked suture. And finally, you have a purse string suture. Purse string is very interesting. And you should also see the module on rectum and anal canal benign disorders, where I've demonstrated purse string sutures in a very interesting manner. So I'll keep it a surprise till you watch that module that I've demonstrated how this purse string suture is done. Now, in a purse string suture, we take a continuous circular bite, and when we tie it, the mouth closes. Right, the mouth closes. That is a purse string suture. I will demonstrate a video of this as well. But where all are purse string sutures used? Purse string sutures are used for cervical encirclage and gynae. Dr. Sakshi must have covered this. Cervical encirclage, if you have an incompetent cervix. Then it is used to bury the appendicular stump. It is used to bury the appendicular stump. And it is also used for fixing feeding tubes. It is used for fixing feeding tubes, and it is also used in Thiersch wiring in rectopexy. Thiersch wiring for rectal prolapse. So these are the places where a purse string suture can be used, and I will just demonstrate to you how these sutures are now taken. So till now I've told you about interrupted sutures, about mattress sutures. I've shown you subcuticular sutures as well. The only thing left is a continuous suture. So subcuticular sutures were also continuous, but there the bites were being taken from inside. In a continuous suture, we are going to take bites from outside. So if I'm closing the rectus sheath for that matter, I'm going to take bites from outside, and you can see that bites are being taken from outside, and you're going to get an appearance like this, where you enter at right angles, you come out from the other side, and these are how the bites are taken. This is continuous suture. Now, one thing which I want to tell you here is how do we close a continuous suture at the end? Okay, so when we reach till the end, then we are going to use an Aberdeen's knot, right? So if supposing I've reached the end here, so I am left with a loop, and I'm left with one thread. So here we are going to take the Aberdeen's knot to close the continuous suture. And how is this Aberdeen's knot taken? The other name for Aberdeen's knot is the cobbler's knot. So if you've got your shoes fixed, you would have seen this knot as well. So what I'm doing here, you can see that I'm using my fingers to create this triangle, and then I'm going to use my finger to draw out this thread through this triangle again. And you must have seen your residents do this, and they enjoy this activity so much that they just keep on doing it, right? It's so satisfying that you just keep on drawing this thread through this triangle. And then in the end, once I've passed it 4 or 5 times, then all I need to do is I need to pass this needle through this triangle. So when I pass this needle through this triangle, I started with one thread and I'm ending with one thread. Can you see the knot has formed and I've ended with one thread? And now what I can do is I can just take a bite and I can bury this thread. I can just bury this thread. So that is how we take a continuous suture. So we've discussed about continuous sutures as well, and I told you I've covered purse string sutures in a very interesting manner in the rectum and anal canal module. So I want you to watch that module to figure out how a purse string suture is taken. 2 more techniques which have not been asked in the exams but are potential questions for future exams. Let me just quickly cover them. One is a far near, near far suture. So this is used for obliteration of large cavities. This is used for obliteration of large cavities. So we can take a far near, near far suture. And in far near, near far suture, what we do is the first bite is a far bite, right? This is the first bite. Then we are going to go near. This is near on the other side. So this is near first bite on the other side. Then we come to here. Then this is near second bite on the same side. And then we are going to come back and we are going to take the far second bite on the other side. So far near, near far suture. This helps in obliteration of the cavity, right? And this is your far near, near far suture. A simple suture cannot obliterate a large cavity as well as a far near far suture. This is the shoestring method for fasciotomy wound closure. Fasciotomy is done whenever there is a compartment syndrome. Compartment syndrome I've also covered in the trauma module. You must have also read about compartment syndrome in orthopedics. And in compartment syndrome, we cut down right till the deep fascia and the muscle bulges out. Now, when the muscle bulges out, you can't suture it in one go because there is not enough space, right? The sutures will cut through. So there what we do is we carry out delayed closure. Gradually we close it. And we close it like a shoestring. You must have seen that if you want to tighten your shoelaces, you just pull on them and it becomes tight. Similarly, we gradually keep on pulling on these sutures and gradually the defect closes over a few days. So this is delayed closure. This is also known as tertiary intention, healing by tertiary intention or delayed primary closure. This healing I've covered in the plastic surgery module about primary intention, secondary intention and tertiary intention. It has also been covered in pathology by Dr. Illa. I have covered wound healing in the plastic surgery module and you can refer to that for primary, secondary and tertiary wound healing points. So these were the various suturing techniques which were there. Now, whenever we have to do suturing, the suture has to be mounted on a needle. So that's the next thing which we'll talk about. We'll talk about needles now. If you look at a needle, you have a swaged end of the needle, right? The swaged end is where the thread is attached, right? So this is the pointed end of the needle. This is the pointed end. No points for guessing this. Then you have the body and this is the swaged end. The swaged end is where the thread is attached. That is known as the swaged end. Mind you, it is not swag, it is swaged. And this has been asked in the exam. So this is the swaged end. Another question which you should know for the exam is where do we hold the needle, right? So the needle is held at the 1/3, 2/3 junction. It is 1/3 from the swaged end and it is 2/3 from the pointed end. So it is 1/3 from the swaged end and 2/3 from the pointed end. This question has also been asked in the exam. Now, needles can primarily be of two types. You can either have round body needles or you can have cutting or reverse cutting needles. So round body needles or you can have cutting or reverse cutting needles. So round body needle is when the cross section of the needle is rounded, right? So what do I mean by this? Supposing this is the needle, and if I break the needle from the center, it will have a rounded cross section, right? So this is a round body needle, okay? So if this is the needle and if I break the needle from the center, this has a rounded cross section and this type of needle is relatively atraumatic. It is relatively atraumatic and it just splits the tissue. It does not cut through the tissue. It splits the tissue. So when it is relatively atraumatic, you are going to use it for delicate structures. Now, what are the delicate structures you are going to use it for? You will use it for bowel, blood vessels, bladder, urinary bladder, CBD, common bile duct, right? So you can remember all of them with B's: bowel, blood vessels, bladder, CBD. All these delicate structures, we are going to use a round body needle. Where do we use a cutting or a reverse cutting needle and what does it look like? So cutting or reverse cutting needle is that when I break the needle from the center, I will get a triangular cross section, right? And in a cutting needle, the apex of the triangle faces inwards, whereas in a reverse cutting needle, the apex of the triangle faces outwards. So that is the only difference. There is a triangular cross section. In cutting, it faces inwards. In reverse cutting, it faces outwards. And as the name suggests, it cuts through the tissue. And when it cuts through the tissue, it does cause some trauma, right? But it is useful for thick, tough structures. For thick, tough structures, we are going to use cutting or reverse cutting needles. And what are these thick, tough structures? You have skin, sheath, and fascia. So for skin, sheath, and fascia, you can remember them with S, skin, sheath, fascia. We are going to use cutting or reverse cutting needles. Now, a very common mistake which an intern makes when they join the surgery department is, when they're asked to suture, the first year postgraduate is always busy. So he'll just tell the basics that this is how you suture. And then they are left independently after 1 or 2 cases. Now, they don't have so much of idea about needles. So whatever needle the nurse gives them, they start suturing with that. Now, a common mistake is that they will be suturing the skin, but they will be using a round body needle. Now, a round body needle is not meant to go through a tough structure. It won't go through a tough structure only, right? So what is going to happen? The poor intern will keep on pushing it, will put all his pressure and all his force to push it through the skin. It won't go through. The needle would just start bending, and eventually the needle would snap, right? So I'm sure a lot of you watching this video as interns, you would have made this mistake, right? So in future, please remember that if you have to suture the skin, always use a cutting or a reverse cutting needle, never a round body needle. Now, in the latest Bailey, they've given some special types of needles as well. Half circle needles are used for GI tract. J-shaped needles are used for vaginal surgery. Quarter circle needles are used for the eye, and compound curvature for the oral cavity. This has not been asked in any exam, but because it was given in Bailey, I just thought I will enlist it here. So now we've discussed about knotting techniques, about suturing techniques, about needles. Now we have to discuss about the various types of suture materials. And when you've gone to the surgery posting or as interns, you would have seen so many suture materials, various shapes and colors. But what exactly do they mean? That is what we'll discuss now. So first, there can be some broad color coding, although there is no hard and fast rule. But you can know that brown, catgut is usually brown, vicryl is usually violet, proline is blue, silk is black, even PDS, polydiaxone, can be black. So this is just a very arbitrary color coding. You can remember this. It's not been asked in any exam. The other thing which I want you to know is regarding the numbering of suture materials, right? So the numbering of suture materials, you would have seen that there's a number written on the packet. What does that number mean? So the thickness of a suture material is 1/10 of the diameter in millimeter. 1/10 of the diameter in millimeter, that is the thickness of the suture material, and that is what the numbers denote. Now, you would have seen that there is a number 1 suture, then you can have a 10, a 20, 30, you can have 40, this can go up till 10, 11. Now, what exactly does this numbering mean? Now, out of these, the thickest suture is a number 1 suture. So, number 1 suture is the thickest suture which is there. Okay, it is the thickest suture, right? Whereas, once you add a 0 and the number increases, then the suture keeps on becoming finer. So, 11-0 will be the finest suture, will be the finest thread which is there. Now, when the suture is thick, it is easier to handle. It is easier to handle, and it fractures less commonly. Okay. Whereas if you have a fine suture, it is difficult to handle. Of course, such fine sutures you have to see only under the microscope, and they fracture more commonly as well. They fracture more commonly, or they break more commonly as well. So this is the broad difference in the numbering, and you should know the basic numbering. Now, what are the various uses of these sutures? So 3-0 sutures we use quite frequently. 3-0 are used for skin, right? So we use for skin suturing. Like I told you, 4-0, 5-0 can also be used by cosmetic surgeons to suture the skin as well. For face, we can use 6-0 sutures as well. And microvascular repair for very fine surgery, we can use 9-0, 10-0, 11-0 sutures as well. 10-0 sutures can be used for cataract surgery and for microsurgery as well. When I talk about the types of suture materials, I will tell you the uses of each one of them. Now, there are various classifications of suture materials, and one of the classification of suture materials is to divide suture materials into natural sutures and synthetic sutures. So sutures can be divided into natural sutures or they can be divided into synthetic sutures. So natural sutures come from natural sources and they will have antigens present on them. Wherever they are being taken from, they will have antigens present on them. And if antigens are present on these sutures, when they are used in a person, these antigens will mount a strong inflammatory response, right? So that is why there is a strong inflammatory response whenever natural sutures are used, whereas synthetic sutures are more inert. So the inflammatory response is not as strong, they are more inert, and this question has been asked in the exam. In fact, the most inert suture materials are synthetic non-absorbable sutures. So you should know about this. Synthetic non-absorbable sutures are the most inert suture materials. Now, these natural suture materials undergo proteolysis. They undergo proteolysis, right? When they are being dissolved in the body, they undergo proteolysis, and the examples of natural suture materials are silk, which is derived from silkworm, catgut, which is derived from the submucosa of sheep gut. Synthetic suture material undergo hydrolysis, and that is how they dissolve. They undergo hydrolysis, and the examples of synthetic are nylon, PDS, proline. These are some examples of synthetic suture materials. I will cover this in detail as well when I talk about further classifications. Another way to classify suture materials is to have monofilament sutures and braided sutures. Monofilament and braided sutures. So monofilament suture means a single thread. A single piece of hair is a monofilament suture, right? So it is a single thread, that is monofilament. Whereas braided means when you intertwine multiple threads, right? You must have seen Caribbean people getting hair braiding done, right? You must have seen the likes of Chris Gayle. If you follow cricket, their hair are braided, so they get multiple hair intertwined, right? So multiple threads are intertwined. Multiple threads are intertwined, so that is braiding. Multiple threads are intertwined. So monofilament sutures versus braided sutures, what are the differences? Monofilament sutures are more difficult to handle, okay? And they have a strong memory. So memory means the ability of the suture material to retain its shape, right? I have demonstrated this to you in the various videos also, which I've shown you, that when you take out a suture material, it will retain the shape of the packet. That is the memory of the suture material, okay? So even if I straighten it out, it will again try to wind itself up. So they have a strong memory and they are difficult to handle, which is why monofilament sutures, more knots are required to keep them in place. More knots are required to keep them in place. Whereas braided sutures are easier to handle. They are easier to handle, okay? And they are easier to knot as well. So I'm sure as interns you all would have worked with silk. And if you're using silk sutures, you just have to tie the knot 3 times. But if you're working with nylon or PDS or proline, you need 6 or 7 knots to keep the thread in place. Otherwise, it opens up because it has a stronger memory. Now, one problem with braided sutures is that braided sutures, I told you, you have multiple threads intertwined. And when there are multiple threads intertwined, in these crevices or spaces, bacteria can grow, right? So bacteria can grow in the spaces of these braided sutures. And that is why there is a higher rate of wound infection. There is a higher rate of wound infection in patients with braided sutures, where braided sutures are being used. Now, what are the examples of monofilament and braided sutures? Monofilament sutures, the examples are catgut, proline, PDS or polydioxone, right? Nylon, these are all monofilament sutures, right? Monocryl. Whereas braided sutures are vicryl, silk. These are braided sutures which are there. So these are the differences which I wanted you to know about monofilament and braided sutures. Now coming to the main classification, the main classification is which classifies sutures into absorbable sutures and non-absorbable sutures. This is sometimes asked as a short note in the college exam as well. So first we are talking about absorbable sutures. And absorbable sutures can be divided into natural sutures and they can be divided into synthetic sutures. Okay, so that is the differentiation. You can have natural absorbable sutures, you can have synthetic absorbable sutures. So absorbable sutures, natural sutures, first one is catgut. Catgut, I told you, is derived from the submucosa of sheep gut, not catgut. It is submucosa of sheep gut. This has been asked in the exam, and this undergoes phagocytosis and enzymatic degradation, right? Undergoes phagocytosis and enzymatic degradation, and the suture completely goes away in 7 to 10 days. So it cannot hold the tissue for a very long period of time, just 7 to 10 days. If you coat it with chromic salts, it becomes chromic catgut, and chromic catgut has a tensile strength of 21 to 28 days. By tensile strength, I mean that it can hold the tissue together for 21 to 28 days. That is the tensile strength of the suture. And complete absorption occurs in 90 days. Complete absorption will occur in 90 days for chromic catgut. Now, if you read the latest Bailey, they've categorically written that these days in surgery, catgut and chromic catgut hardly have any role. They are hardly used in surgery. But if you're working in a government institute, you will come across catgut and chromic catgut, and you mainly use it to approximate the subcutaneous tissue. So these were natural absorbable sutures. You can have synthetic absorbable sutures as well. Now we'll talk about synthetic absorbable sutures, and the first one which we need to talk about is monocryl. So monocryl is polyglycopyrrone. That is the chemical name for monocryl, polyglycopyrrone. And this is a monofilament suture. As the name suggests, this is a monofilament suture. And the main utility of monocryl is for skin suturing, and it is used for subcuticular suturing. I've already told you subcuticular suturing it is used for. Subcuticular suturing is cosmetically better, and we usually use a 3-0 or a 4-0 or a 5-0 monocryl to carry out this suturing. 3-0 is most commonly used. Now, because we are suturing the skin, which needle will we use? Which needle are we going to use? We are going to use a cutting or a reverse cutting needle here. Okay, not a round body. We will use a cutting or a reverse cutting needle in this case. So this was the first synthetic absorbable suture material, that is monocryl. The other one which is very commonly used in surgery is vicryl. Now vicryl is polyglactin. That is the chemical name for vicryl, and vicryl is a braided suture. That means you have multiple threads which are intertwined to form a vicryl thread. So this undergoes hydrolysis. Vicryl dissolves by hydrolysis, and the complete absorption takes place in 60 to 90 days. So in 60 to 90 days it gets completely absorbed. And the tensile strength of vicryl is 60% at end of first week, 60% at the end of first week, and 30% at the end of third week. That is how well it can keep the tissue together. That is the tensile strength. So these are the points in vicryl which you should know about. Now, what are the uses of vicryl? I showed you Vicryl when I was doing the suturing exercises. I did show you Vicryl. It is violet in color. This is used for bowel anastomosis. This is used for bladder repair, bowel, bladder. This can also be used for CBD, although these days we don't use this. We use PDS more commonly. So bowel and bladder, it is 3-0 round body needle because these are delicate structures. CBD, it is usually 5-0 on a round body needle because CBD is also a delicate structure. Now, Vicryl can also be used to approximate subcutaneous tissue together. So I also use Vicryl in my breast surgery. Okay. So these are the uses of Vicryl. Now there are certain special types of Vicryl which are there, and these special types have also been asked in the exam. So the special types of Vicryl, you can have Vicryl Plus. Vicryl Plus is antibiotic coated Vicryl. And why do we want antibiotic coating on the Vicryl? Because Vicryl is a braided suture, and we discussed that in braided suture in the crevices bacteria can grow and there can be more risk of infection. So this Vicryl Plus is coated with triclosan. It is coated with triclosan and it is antibiotic coated Vicryl. You can have barbed Vicryl. You can have barbed Vicryl. Barbed Vicryl has spikes in it. This is what barbed Vicryl looks like. It has these spikes in it, and the advantage of barbed Vicryl is that it anchors in the tissue. When you take it, it just anchors there. So you don't need to tie a knot. Even if you don't tie a knot, the suture will still remain in place, right? Suture will still remain in place. That is a barbed Vicryl. And barbed Vicryl, where do we use it? So we use it for facelifts, right? Sometimes on social media, I'm sure you must have seen these very old actors. They are on the good side of 50 or 60, but their face looks as if the face is of a 30-year-old, right? Because all of them get Botox done and they get facelifts done. So when they go for these facelifts, what the dermatologist or the plastic surgeon does is they just thread this barbed Vicryl in front of the ear. They thread it from here and they anchor it with the scalp. They anchor it with the scalp. So the face gets lifted up like this. It gets a toned appearance. And the advantage is you don't need to tie a knot. But the disadvantage is it is very painful, right? Anything with thorns in it will be painful. The third type of Vicryl which you have is Vicryl Rapid. And Vicryl Rapid is polyglactin 910. And this dissolves in 21 to 28 days. Okay. So rapidly dissolving Vicryl, it has features which are similar to chromic catgut. So it behaves like chromic catgut. That is Vicryl Rapid. So these were the various types of Vicryl. We were talking about synthetic absorbable sutures. We've spoken about monocryl. We've spoken about Vicryl. And the third one which we need to discuss is PDS. PDS is polydioxone. This is also a monofilament suture. And this PDS dissolves in 180 days. So this dissolves in 180 days, almost double to triple the time of Vicryl. Now the uses of PDS are the same as Vicryl, but this is preferred because it is a monofilament suture. That is why it is preferred over Vicryl, but more expensive than Vicryl as well. And PDS is also used for tracheobronchial repairs. So we've spoken about absorbable sutures. We now shift our attention to non-absorbable sutures, right? Non-absorbable sutures can also be divided into synthetic sutures and natural sutures. So there can be natural non-absorbable sutures and there can be synthetic non-absorbable sutures. So natural non-absorbable sutures include silk, and again I'm going to write it with black because silk is black in color. This is derived from silkworm. And it does incite a strong inflammatory reaction because it is a natural suture. The uses of silk It is used for skin suturing. Of course, we these days prefer better suture materials, but of course in medical colleges, silk is still used for skin suturing. So we will use 30 on a cutting needle. This we've already discussed. It can be used to fix drains, and the heavy drains, the abdominal drain, the chest drains, we use number 1 silk on a cutting needle because we have to fix it with the skin itself. It is the second layer of bowel anastomosis. So second layer of bowel anastomosis, we use silk, and it is 30 on a round body needle because bowel is a delicate structure. So these are the uses of silk, which is a natural non-absorbable suture. The synthetic non-absorbable sutures which you need to know about. The first one is Prolene, very important for the exam. Multiple questions have been asked. Prolene is polypropylene. The chemical composition is polypropylene, and it is a monofilament suture. It is polypropylene, and it is a monofilament suture. It is blue in color. Blue in color. Now, Prolene, what are the uses of Prolene? Very important. Number 1, it can be used in a hernia mesh. Right, in the hernia module, we'll talk about mesh plasty or hernioplasty, and the mesh material, the most common mesh material is Prolene. Then this is also used for rectus sheath closure. It is used for rectus sheath closure. And rectus sheath closure, we are going to use a number 1 Prolene on a cutting needle because sheath is very thick. So number 1 Prolene on a cutting needle is used. And one point which you should know, which has been asked in multiple exams, that when we are closing the rectus sheath, we follow the Jenkins theory of mass closure. We follow the Jenkins theory of mass closure. And the Jenkins theory also states that to close the rectus sheath wound, we need the thread should be at least 4 times the length of the wound. At least 4 times the length of the wound. This has been asked in many exams. So you should have an adequate length. You should not use a short thread to close the rectus sheath. And what is the reason behind that? Let me just demonstrate that to you. So in medical colleges, whenever rectus sheath is to be closed, it is usually handed over to the first year postgraduate. Now these first year postgraduates are really enthusiastic, right? And they want to show to their seniors that they're doing a good job. So they will take the Prolene and they will take continuous sutures, right? They'll take continuous sutures. So they'll take a bite from here and then a continuous suture will be taken. So they'll take another bite adjacent. And they want to show to the senior that they are doing a good job. So they're going to pull it with all their strength, right? They will utilize all their strength to pull it. And they think that they are doing a good job by pulling it. But when they are pulling it so tightly, they are actually creating a lot of tension, right? They're using a shorter thread to close the sheath. They're creating more tension. And if they pull it too tightly, ultimately what is going to happen, that it is going to cut through the sheath. It is going to cut through the sheath. And if it cuts through the sheath, you will read in the next module that a burst abdomen can develop. The sheath can open up and a burst abdomen can develop, right? So that's the problem, which is why we don't prefer shorter threads. We should use adequate length so that there is less tension in the repair. And short bites should be taken as compared to long bites. This also I have discussed in the next module where I've spoken about burst abdomen and the factors which lead to burst abdomen. But you should know that 4 times the length of Prolene should be used for rectus sheath closure. The third utility of Prolene, which has also been asked in multiple exams, is vascular repair or anastomosis. And vascular repair or anastomosis, we will again use a round body needle here. And 20 is used for the abdominal aorta. 40 is used for femoral. And 60 is used for popliteal. So as the diameter of the vessel becomes narrower, the thread will also keep on becoming fine. Of course, for microvascular anastomosis, you will use a 10-0 or a 11-0. Now, when we are doing a vascular repair, few points which I want to cover here in vascular repair, I want to cover here only, that there is a Carroll's triangle which is created. There is a Carroll's triangle which is created when we are doing vascular repair. So please remember this term, Carroll's triangle. Now, when we do a vascular repair, this is the vessel which is there. And we are going to put clamps on both the sides. Which clamps do we use? We will use bulldog clamps, right? And these bulldog clamps I have covered in the instrument module. So we are going to put bulldog clamps, vascular clamps on both the sides. This is proximal, this is distal, and this was the area which I was repairing. So once I use the Proline to repair this area, then first I release the distal clamp. First release the distal clamp. So why am I releasing the distal clamp? Because where I was repairing, air is there in that cavity. In this segment, air is there and I want air to go away. So first I release the distal clamp so that the blood can come back, flow retrogradely and fill that area and air goes away. And then proximal clamp is released. Then proximal clamp is released to see if watertight repair is there or not. If it is a watertight repair or not, then we release the proximal clamp. So these are the basic steps for a vascular repair and we are using Proline there. So we were talking about synthetic non-absorbable sutures. We've spoken about Proline. The other one which I want you to know is nylon. Nylon is also very frequently used. Nylon is also known as ethylon. Now, nylon is also a monofilament suture. Nylon is also a monofilament suture, and the uses of nylon are the same as silk. But it is preferred because it is monofilament and it is synthetic. And N for nylon, N for nerve repair. It is also used for nerve repair. It is used for tendon repair as well. It is used for tendon repair. And 10-0 nylon is used for cataract surgery. As well. Another synthetic non-absorbable suture is polyester. Polyester goes by the name of ethibond. Polyester or ethibond. And this is also used for tendon. This is also used for sheath. Tendon and sheath. Polyester or ethibond can also be used. You can have steel sutures. And steel sutures are mainly used to close the sternotomy incision. The sternotomy incision after coronary artery bypass grafting after CABG. I'm sure you must have seen x-rays or chest x-ray where you would have seen wires around the sternum. So those are actually steel sutures which are used to close the sternotomy wound after a CABG. And finally, you have polybutester. Which is used for plastic surgery. So these are the synthetic non-absorbable sutures which you should know about. Now I'll keep on showing you some of the pictures all throughout the surgery module. These are the pictures which I have clicked. I'm very fond of wildlife photography and bird photography. So this was in Jaipur where I clicked this picture and you can see the beautiful blue coat of this peacock. The Proline suture color is exactly same as this bluish coat of the peacock, and I've also shown you this suture when I was showing you the suturing demo. Now when we use a non-absorbable suture, these non-absorbable sutures, we have to remove them as well. So removal of this suture, what are the various times? So over the scalp, they can be removed in 5 to 7 days. 5 days is a better answer. So remember, 5 days is a better answer. Face is the earliest when we can remove sutures, right? So we can remove sutures as early as 3 days over the face. And the advantage also is that it does not leave behind the mark. Because if you leave a suture for a very long period, it will leave behind a mark. So over the face, if you remove it early, it does not leave a mark and it can be removed as early as 3 days. Neck is 5 to 7, thorax is 10 to 12, abdomen is 12 to 14, and perineum is 10 to 12 days. So these are the various times when we can remove sutures from various parts of the body. So we've spoken about the classification of sutures. Now the final thing which we need to discuss in this module is regarding bowel anastomosis. Now bowel anastomosis, how is it different from skin suturing? So in bowel I told you we want inverted edges. right? In skin, we wanted everted edges. Here we want inverted edges, okay? So inverted edges are required in bowel. And bowel anastomosis, there are various techniques. There are 3 techniques which can be done for bowel anastomosis. You can have the single layer technique, you can have the 2-layer technique, or you can have stapled bowel anastomosis. So it can either be single layer. This is known as single layer extramucosal repair. You can have 2-layer repair, or you can have stapled bowel anastomosis. So the first thing which I want you to know, whether you do a single layer, a 2-layer, or a stapled anastomosis, all have the same outcome. So the results are the same, so you can choose either one of them, provided they are done properly. Now the single layer extramucosal repair. So the name itself suggests that we are not taking the mucosa. And one thing which you should remember, that the strongest layer in bowel anastomosis, and this question has been asked many times in the exam, the strongest layer is the submucosa. The strongest layer in bowel anastomosis is the submucosa. Okay, so what is done in single layer extramucosal repair, you can see here, this is single layer extramucosal repair, and this is the mucosa, this is mucosa, this is submucosa, this is the muscle layer, and this is the serosa, which is the outermost layer. And you can see that we are taking a single bite, but we are not taking the mucosa, so that ischemia of the mucosa does not occur. This is single layer extramucosal repair. The other one is a 2-layered repair, and this 2-layered repair was described by Cocker. The 2-layer repair was described by Cocker, and this is what we used to do as postgraduates. This is what we were taught initially. Now in the 2-layer repair, the first layer which is taken is, first layer is taken using vicryl, and all the layers are taken. And this first layer is known as the Albert layer. So you can see here that I'm taking the first layer, which I've taken all the layers here, and this is the Albert layer which is taken, okay, and this is usually vicryl. Now the second layer, this is the second layer which is taken, and the second layer is taken using silk. Again, round body, because bowel is delicate. This is taken using silk, which we know we are going to use on a round body needle because the bowel is a delicate structure, and this is the one which causes inversion. And this is known as the Lambert layer. So the second layer is known as the Lambert layer, which causes inversion, and this is the silk layer. So this is the 2-layer Cocker anastomosis which is done, and the final one is using staplers. I have shown staplers in various surgeries in the GIT module. So you should know this one is the linear stapler. Images have been asked in the exam. This is your linear stapler, and this is your circular stapler. This is the circular stapler which is there. So linear stapler and circular stapler. Linear stapler can be used in places like sleeve gastrectomy, which is a bariatric surgery. You can see in the bariatric surgery or weight loss surgery module. This can be used for gastrectomy. I've shown it in the stomach 1 and stomach 2 module as well. Circular stapler. Circular stapler can be used for LAR, low anterior resection, which is rectal cancer surgery, low anterior resection. It can be used for stapler hemorrhoidopexy, which is the procedure of choice for hemorrhoids these days. And I've shown a video also of stapler hemorrhoidopexy in the rectum and anal canal benign module. So these are the places where we can use a circular stapler. It can also be used for esophagojejunostomy after total gastrectomy. So these are the places where circular stapler can be used. And whenever we use a stapler, the most common complication is bleeding from the staple line. So these are the points which you should remember. Now there are two more terms which I want you to remember when we talk about bowel anastomosis, because they've been asked certain times in the exam. The first one is a Cheadle's split. What exactly is a Cheadle's split? So this is a longitudinal split. along the anti-mesenteric border, when there is luminal disparity. Okay, so what does this mean? Let me just demonstrate this to you. Now, supposing we've done a right hemicolectomy, right? Right hemicolectomy is when terminal part of ileum, the cecum ascending colon and the right half of transverse colon is removed. That is right hemicolectomy. Now, when right hemicolectomy is done, I have to anastomose the ileum with the colon. Now, ileum has a narrower lumen, whereas colon has a wider lumen. Now, I cannot do end-to-end anastomosis because there is luminal disparity. Okay, so either I will do an end-to-side anastomosis, or the other option is I can make a cheatal split. Okay, and this is just giving an arbitrary example for you to understand cheatal split. So cheatal split would be that along the anti-mesenteric border, anti-mesenteric is where the bowel blood vessels are not there. That's why I'm making it here. I don't make it along the mesenteric border because the mesenteric border has the blood vessels. So if I make a longitudinal split along the antimesenteric border, the mouth opens up. You can see the mouth has opened up. And now I can anastomose it with the bowel with the larger lumen. Okay. So cheatal split helps us in carrying out anastomosis when there is luminal disparity, and it is a longitudinal split made along the antimesenteric border in the bowel with the narrower lumen. So we make it in the bowel with a narrower lumen and antimesenteric so that we don't cut the blood vessels. The other term is Connell's loop. Connell's loop is taken at the edge of the anastomosis. The edge of the anastomosis is the one which leaks most commonly. Okay, that is the one which leaks most commonly. So Connell's loop is taken at the edge of the anastomosis to ensure inversion of mucosa. That is a Connell's loop. So this takes care of bowel anastomosis as well, and to carry out bowel anastomosis, to secure the bowel, we use bowel clamps, which I've shown in the module where I've spoken about instruments in great detail. Now this takes care of this module. Now for final year students, the only thing which is asked as a short note from this module is the classification of sutures. So that is what I want you to remember. Short note, you should know absorbable and non-absorbable sutures, absorbable versus non-absorbable sutures. This is what is asked in your exam, the classification. Other than that, nothing is asked, but it is a very important module from the practical point of view and for your entrance exams. So before we end this module, let's quickly do some MCQs. What is the ability of the suture material to retain its shape after removal from the suture packet known as? So there are certain definitions which I want you to know, right? One is plasticity. Plasticity is a measure of the ability to deform without breaking and to maintain a new form after relieved from a deforming force. Okay, so that means I remove the suture material, I give it a tug. And when I give it a tug, if it remains straight, that is the plasticity. Elasticity is the measure of the ability to regain its original form and length after deformation. So one term is memory. Memory is the measure of ability to retain its shape. Without a deforming force. Without the deforming force. So when I bring it out of the suture packet, if it coils up again, that is the memory of the suture. But the elasticity of the suture is when I take it out from the suture packet, I pull on it and still it coils up. That is elasticity. Okay. Pliability is the ease of handling the suture. Right. So what is the ability of the suture material to retain its shape after removal from the suture packet? This I just told you, without deforming force, the answer is going to be memory. But if it was with a deforming force, the answer would have been elasticity. So we've spoken about monofilament sutures and braided sutures. And I told you that braided sutures, multiple threads are intertwined to form that suture. So this one is a vicryl suture. You can see it is violet in color. And this vicryl suture, you can see that even if I'm not touching it, it is lying straight. Okay, so this does not have a strong memory and I can easily utilize it. So the ease of using Vicryl is more. But this one is a Prolene suture. You can see it is blue in color, and you can see that even if I straighten it out, it coils up again, right? So it has a very strong memory. Monofilament sutures have a strong memory. That is why they are not easy to handle, and you need more knots to keep a monofilament suture in place. At what angle should the needle be inserted while suturing? While taking interrupted sutures? This I demonstrated to you when I was showing you the demo. This is 90 degrees and this was recently asked in the INI CET exam. This is 90 degrees. This was asked in the INI CET exam that the needle should make a 90-degree angle with the skin. You can see here. Which of the following is not true regarding skin suturing? Distance between two sutures should be 2 times the depth of the wound. This is true. Mattress sutures should be used if simple sutures are unable to cause eversion. This is true. Round body needles are used for skin suturing. No, I told you, don't make that blunder. This is false. Monocryl is one of the best suture materials for subcuticular suturing. This is true. Which of the following is not an absorbable suture? So you can be given such tricky questions where all the chemical names are there and you can be asked which is absorbable, which is not. Now, polyglactin we know is Vicryl, which is absorbable. Polypropylene is Prolene, which is non-absorbable. Prolene, which is non-absorbable. Polyglycopyrrone is Monocryl, which is absorbable. And PDS is polydioxone, which is also absorbable. What is the best suture material used for this technique? This is subcuticular suturing. We've discussed multiple times during this module. It is monocryl on a cutting needle. This was asked twice in the AIIMS exam. This was a question in the INI CET and the PGI exam. You're given 2 suture packets. One is a number 1 suture, whereas the other one is a 10-0 suture. You have to review the statements. 10-0 is finer as compared to number 1. This is true. I've discussed this. Number 1 sutures are easier to handle as compared to 10-0. This is also true. Number 1 sutures are likely to fracture more commonly. False. Finer sutures fracture more commonly. So 10-0 will fracture more commonly. 10-0 nylon can be used for cataract surgery. This is true. So A, C, D are correct. So that option is not there. You can add that option. A, C, D is correct. Review the following procedures and suture materials. Which of the following has not been correctly matched? CBD repair, PDS on a round body needle. This is true. It is usually 5-0. Vascular anastomosis, we use Prolene on a round body needle. This is true. Rectus sheath, Prolene is used but not on a round body needle. It is a cutting needle because the sheath is very thick and we need a tough needle to go through it. Nerve repair is nylon on a round body needle. This is also true. So that brings us to the end of this module, which is very important from the entrance point of view. Thank you.